Hello everyone, I'm Danny Roddy, and I wanted to welcome you to the first week of Organizing the Panic, where we're going to talk about the Genetic-Androgen Hypothesis and kind of the history behind it, the mechanisms, and how it became kind of a doctrine of what causes pattern baldness or androgenic alopecia. So before we get too far, I wanted to explain how the slides are laid out. On the left-hand side is the original source for the information that you're hearing via the audio, as well as the right-hand side, which is the written text. So feel free at any time to pause the video and read the highlighted source so you can get extra context for kind of what's being talked about, because many of the times I'm summarizing and just giving you a general idea of what I'm talking about. If you have any questions about anything, ask via the discuss comments in the Facebook group, or feel free to personally just email me, dannyroddy@gmail.com. I hope you guys enjoy it. Happy learning, and here we go. The Genetic-Androgen Hypothesis. Androgenic alopecia is quoted as approaching 100% of all Caucasians. Chinese, Japanese, and African Americans show less balding. Variations among the groups of people with pattern hair loss is said to be genetic. And as we go on, you'll notice that there's a trend in hair loss research to explain seemingly unexplainable things on the genes. Obviously, anybody listening to this understands that balding in a youth-oriented culture has negative connotations. Research suggests that baldness causes a marked physiological distress and reduction in the quality of life of men and women. Patients report poor self-image, feelings of being older, and loss of self-confidence. Other people view those with baldness as older, less attractive, weaker, and duller. Androgens, e.g. testosterone and dihydrotestosterone, or DHT, are believed to be the main regulators of hair growth. During youth, androgens grow long, thick, pigmented hairs. However, it is believed that in those with a genetic predisposition, androgens cause the miniaturization of scalp hair over time. Despite the cultural stereotype, those with baldness tend to have normal levels of androgens. So according to the Genetic-Androgen Hypothesis, an inherited genetic sensitivity to androgens, coupled with normal levels of testosterone or DHT, which are both androgens, cause pattern baldness. To understand the context of how the Genetic-Androgen Hypothesis formed, we must travel back in time and review the history, starting with Dr. Hamilton and his eunuchs. In 1942, Dr. James B. Hamilton changed the course of hair loss research with his groundbreaking study in a group of 104 men who failed to mature sexually, i.e. eunuchs or eunuchoids. Both young and old, the men were unified by testicular insufficiency, which Dr. Hamilton found to give rise to three anomalies. First, they had complete retention of head hair. Second, they had reduced oily secretion from the sebaceous glands. And third, dandruff was either decreased or completely absent. Here's a photo of Dr. Hamilton's castrates, and both of them are sporting a pre-pubertal hairline. Upon receiving testosterone injections, Dr. Hamilton learned that castrates who were normally immune to baldness began to bald. Balding occurred in the forehead, the frontoparietal regions, and the crown of the head. Castrates experienced increased sebaceous gland activity, resulting in oily skin and dandruff. That a characteristic unifying all the men was the prevalence of pattern baldness in their family. And the amount of testosterone needed to induce baldness was not greater than the amount in a young adult male. Hamilton believed that pattern baldness was the cross-section between genetic predisposition and normal levels of male androgens. Dr. Hamilton's 1940s work forms the foundation for current pattern baldness research. To summarize, men who failed to mature sexually were immune to inherited pattern baldness 100% of the time. However, men who failed to mature sexually, when given testosterone injections, began to bald in a typical pattern baldness fashion. The DHT Connection. In 1974, Dr. Julianne Imperial McGinley, an endocrinologist at Cornell, traveled to the Dominican Republic to observe a remote mountain village with a population of male pseudohermaphrodites called the Guadavoses, which means penis at 12 years. Similar to Dr. Hamilton's eunuchs, the Guadavoses were conspicuously free of pattern baldness and acne. It was discovered that the Guadavoses had normal levels of testosterone, but had a deficiency of the enzyme 5-alpha reductase that converts testosterone into the more powerful male hormone dihydrotestosterone. Here's a photo of Ampero-McGinley's pseudohermaphrodites. To summarize, Dr. Ampero-McGinley found that a 5-alpha reductase deficiency led to deficient levels of dihydrotestosterone, or DHT. However, they had normal levels of testosterone and were immune to pattern baldness, suggesting that DHT was an integral part of the hair loss puzzle. The work of Dr. Hamilton and Dr. Ampero-McGinley wouldn't have meant that much in the broader context of pattern baldness research. However, the pharmaceutical companies stepped in and created what seems to be a doctrine of pattern baldness research: Finasteride, or Propecia. Dr. Ampero-McGinley's work eventually found its way to the desk of Merck's chairman, Roy Vagelos. Like mosquitoes homing in on a picnic, they seized on a phrase in Dr. Ampero-McGinley's description of the guadavoses, whose prostates throughout life remain very small. Here then was a possible clue to a drug that would shrink an enlarged prostate, something that Merck and nearly every other drug company wanted to develop. If levels of dihydrotestosterone could be lowered with a drug that inhibited the enzyme's action, 5-alpha reductase, that drug could find an eager market among the 15 million American men plagued by enlarged prostate, an embarrassing and often painful condition which can block urine flow, interrupt sleep, and cause serious infection. Research and development went into the creation of the drug Proscar. Interestingly, Proscar could regrow hair in those with pattern baldness, and the drug was lowered from 5 milligrams to 1 milligram and renamed Finasteride, or Propecia. Sales of Finasteride bring in almost $500 million a year. A single 1 to 10 milligram dose of Finasteride lowers dihydrotestosterone levels by 60 to 80% in a time-dependent fashion. While the drug's popularity doesn't seem to be slowing down, it's associated with an unconscionable list of side effects, as you'll see in the CNN interview.
The internet guru I spoke to before the break, millions of people swear by their miracle medications, but at what cost? Kevin Malley says the hair loss drug Propecia did more than grow his hair. He says it made him slip into a mental fog, it made him impotent, and even shrank his genitals. Dr. Sharon Berquist from Emory University standing by. But Kevin, those are tough things to admit, especially to the world, coming on national television and doing it, international television. Why do it?
Well, I want to warn other men who might be considering Propecia that this drug is extremely dangerous, and it's not what Merck said it was.
You are part of a class action lawsuit against Merck, the company that makes Propecia. And they say that Merck believes that Propecia, which is Finasteride, has demonstrated safely and inefficacy profiles, and the product labeling appropriately describes the benefits and the risks of the drug to help inform prescribing. So they saw no causal relationship between the use of Propecia and continued sexual dysfunction after discontinuing the treatment. How do you respond to that?
Well, if the warning labels are adequate, why did they have a discrepancy in the warning labels between the continents? And they also changed the warning labels 4 times in the past 2 years. So obviously Merck knows that there is a danger, but they don't want to properly warn the public.
How old were you when you started taking it? How long ago did you start taking it?
I took it off and on from May to October 2011.
And when did you
started noticing serious?
Yeah. When did you start noticing the side effect?
I started noticing severe problems around October. I was doing jiu-jitsu with my girlfriend, and I noticed my body wasn't responding correctly. And then when it was a time for sex, I noticed things weren't responding properly either. So I got off the drug, and I fully expected things to get better, but that's when the side effects got extreme.
What did your doctor say to you?
The exact opposite. Doctor said, there's nothing we can do for you. Give it some more time. And I gave it 6 months. I went back to the doctor. I was worse than ever. And he said, there's nothing I could do for you. I've been on testosterone replacement therapy for a couple months, and that's only had moderate improvements.
Dr. Berquist, to you now, Kevin says it got even worse for him after quitting the drug, and that was almost a year ago. Is that common?
That is not common from these drugs. Again, with these 2 cases, I think they're both have their similarities, but there are also some differences. Of course, In both these scenarios, we have people taking drugs to enhance performance in some capacity or to essentially fight nature. The difference is Mr. Asprey is using this drug essentially in a way that is not its intended use. And he is essentially a guinea pig because we do not know long-term effects and we don't know what happens with unintended use.
So you wouldn't recommend it?
I would not recommend it.
So then how are people going in, though, and getting prescriptions for drugs where they don't have that particular ailment?
I think there are several different scenarios. I think one is some physicians are maybe not as rigorous in their diagnoses of certain conditions.
Should they be?
I think there should be. To your point, you mentioned that anybody could say, I have trouble sleeping, but not everyone who's having trouble sleeping has a sleep disorder. And I think we need to be testing and to be more rigorous to differentiate the people who are more appropriate.
What about more warnings? Because as you've seen the commercial, and it's like, can cause this, and you're like, oh my goodness. I mean, how many more warnings can you get on there?
Yeah. I'm not sure we need to be putting more warnings. I think that what we do need to be doing is comparing the benefits against the potential harm of these medications and making educated decisions based on that information.
Doctors who do it, legal? Is it moral? Should we be looking more into it? Or they're doing what they're supposed to do? They're working within the bounds of being a doctor.
Right. I think, you know, there are two sides to this. From a patient standpoint, I think patients should have that right to make their own health decisions, and we as physicians should help educate to help them get there. However, these are federally controlled substances. And in the case of Provigil, this is a controlled substance with a habit-forming potential. So when you're having a physician prescribe it, you are pulling in ethical considerations as well as legal considerations.
Yeah.
I mean, Don, it wasn't long ago that Michael Jackson's physician was convicted of involuntary manslaughter. So where is that fine line between what is okay and ethical and what is truly causing harm?
Dr. Berquist, thank you very much. And I should tell you again, Kevin has made this his mission. He's part of a class action suit. And when that's finally settled, Kevin, we invite you back to come on. Thank you so much. We appreciate it, okay?
A recent paper entitled The Dark Side of 5-alpha reductase inhibitors detailed a long list of problems associated with these drugs, including loss of libido, erectile dysfunction, ejaculatory dysfunction, anxiety, depression, and suicide. For some men, the side effects are permanent even after discontinuing the drug. Changes in sexual function are among the most prominent side effects of the drug. Interestingly, the pharmaceutical industry attempted to reposition 5-alpha reductase inhibitors as anti-cancer drugs in 2010. However, the drugs significantly increased the incidence of aggressive prostate cancer tumors. Is it possible that DHT plays a protective role in the prostate? It turns out that 5-alpha reductase is needed for the synthesis of various protective neurosteroids, and an experiment using finasteride reduced or practically eliminated levels of these protective steroids. This may explain the anxiety, depression, and suicidal tendencies in some people feel while taking the drug. As mentioned, taking finasteride plays a strong role in depression. And the takeaway, the argument that the benefits of these drugs outweighs the risk is slowly eroding in the face of some new emerging scientific evidence from preclinical and clinical studies. However, it should have been obvious from the very beginning that reducing these hormones in an unphysiological way and attempting to make a man a pseudo-hermaphrodite is a risky endeavor. Here is a short video of Dr. John Chrysler describing the dangers of Propecia.
In order to assess DHT, I look at 5-alpha reductase activity, which is a ratio of, I use several different ratios on the 24-hour urine panel. That's outside the scope of this lecture, but I'll be talking privately. And I am just totally against finasteride. I have had so many patients come to me who that medication has destroyed their life. I've had several patients, there's a Yahoo forum for the finasteride sufferers, and there have been several suicides on that forum. For some reason, some men have systems or endocrine systems are just all set to get broken. And they take finasteride even for as short as a week, and it destroys their lives. They become depressed, weak, impotent. And the problem is when they go off the drug, their symptoms remain. We don't know why. They come in, perhaps if they're hypogonadal, we can do something like that. I try to restart their system. But too often, they have very good testosterone levels, but have all the symptoms of hypogonadism. And that is a very serious problem. These guys are seriously screwed up from taking that drug. I have never prescribed it and never will.
For some men, these side effects may seem like an even trade-off for keeping their hair. However, the drug's effectiveness is up for debate. Merck's homepage for Propecia, or Finasteride, states that the drug is highly efficacious, in the realm of 90%. Regrowing hair in 48% of men, and stopping hair loss in 42% of men. When scrutiny is applied to Merck's claims, however, Finasteride seems less effective. In an excellent article by Jonathan J. Darrow, he points out that there is a 138 hair difference in a 1-inch diameter after 1 year on the scalp, and a 277 hair difference after 5 years. Jonathan goes on to say that while 277 hairs after 5 years may sound impressive, the average number of hairs per square inch is around 2,200. After 5 years, a faithful Propecia user can expect somewhat more than a 10% improvement over what they could expect without any intervention at all. In another study, it was found that Finasteride's efficacy landed somewhere around 40%. In another experiment, a total of 1,261 men were given 1 milligram of Finasteride. After 12 months, only 414 continued to take the drug, but only 211 completed the study. A small percentage felt that they had regrew hair. The remaining patients noted poor results. Additionally, pattern baldness forms reveal many anecdotal accounts of men who failed to see results, experienced life-changing side effects, in addition to a worsening of their hairlines despite preemptive actions of taking Finasteride and other drugs at the first signs of hair loss. In summary, oral use of Finasteride significantly reduces DHT in addition to other mechanisms, has many possible side effects, and has a 10 to 40% chance of hair restoration. Minoxidil. Minoxidil, or Rogaine, is a non-starter for many people due to the tedious nature of applying the substance, which has been shown to be many times less effective than Finasteride. The mechanism of how minoxidil works is unknown. In a study, 1,495 men aged 20 to 40 were given 5% topical minoxidil every day. The insignificant cosmetic effect of minoxidil solution caused abandonment among almost all patients. Minoxidil is associated with the following side effects: scalp itching, dryness, scaling, flaking, irritation or burning, weight gain, swelling, difficulty breathing, rapid heartbeat, chest pain, and lightheadedness. Minoxidil has also been related to the development of hyperprolactinemia and excess of the adaptive stress hormone prolactin. In addition to many other symptoms, an excessive level of prolactin can grow breasts in males, or gynecomastia. Prolactin suppresses thyroid function and cause a variety of symptoms related to inflammation, pain, and sexual dysfunction. To summarize, the topical use of minoxidil has an unknown mechanism, many possible side effects, and results in an insignificant cosmetic effect. The Androgen Paradox. There are two so-called paradoxes in balding research. The first was noted in 1952 by Dr. James B. Hamilton in his original research. While baldness is believed to be an androgen-dependent condition, the chances of balding increase with age, while the inciting agents, or male androgens, tend to decrease. The male androgen, testosterone, which is converted into dihydrotestosterone, or DHT, by the enzyme 5-alpha reductase, tends to decrease with age. Dihydrotestosterone, or DHT, the main hormone believed to be involved in the genesis of pattern baldness, also tends to decrease with age. The second so-called androgen paradox is that androgens stimulate beard growth but suppress hair growth in pattern baldness. Androgens stimulate the gradual transformation of small follicles producing tiny, virtually colorless vellus hairs to terminal follicles producing longer, thick, and more pigmented hairs during and after puberty. However, androgens are believed to inhibit hair growth in genetically susceptible individuals, causing the reverse transformation of terminal follicles to vellus ones. How is this possible? With a bit of physiological gymnastics, these paradoxes are believed to be explained by the androgen's effects on the androgen receptor. Androgen receptors are proteins within the cell that have a strong affinity for dihydrotestosterone and less so for testosterone. It is believed that testosterone enters the cell, some of which is enzymatically converted into dihydrotestosterone, and both enter the nucleus of the cell by attaching to the androgen receptors, which supposedly acts on the hair follicle in a negative way. Are balding men more sensitive to androgens? Because those with pattern baldness don't necessarily have higher levels of androgenic hormones, much research has gone into exploring androgen receptors of those with hair loss. It is very often said that baldness is the result of hypersensitive androgen receptors. However, this seems to be incorrect. Do the balding have more androgen receptors? The second argument is that those with pattern baldness have more androgen receptors in the balding regions of their scalp. The evidence seems to be mixed. For instance, in this study, balding regions of the scalp did indeed have more androgen receptors than those from non-balding areas of the scalp. However, in another study, a high level of androgen receptors was found in the vertex hair follicles of a 73-year-old non-balding man. Moreover, another study suggested that we can add androgen receptor count to our list of androgen paradoxes. In so-called senescent alopecia, or age-related pattern baldness, it was discovered that there was a twofold decrease in levels of androgen receptors when compared to balding males age 18 to 30. Adding to the confusion, 5-alpha reductase inhibitors like Propecia or Finasteride appear to increase androgen receptor levels in animals. A high androgen receptor count in balding regions of the scalp is said to be the result of a genetic predisposition, but something as simple as vitamin A has been shown to decrease the amount of androgen receptors in the tissues from 30 to 40%. So ultimately, the question is, what does the androgen receptor help clarify? Rather than a pre-programmed piece of the organism, androgen receptors may be simply an extension of the organism's interaction with the environment. For instance, androgen receptors are located in the cytoplasm of the cell attached to heat shock proteins, or HSPs. Nobel laureate Barbara McClintock explained that the heat shock proteins were part of the stress adaptation system, allowing change in the organism when the environment allowed. This may suggest that changes in the amount of androgen receptors is a reflection of the organism's interaction with the environment rather than the result of the quote genes. Failed theory. It is hardly mentioned, but Dr. James B. Hamilton, whose research serves as the foundation of all current pattern hair loss research, left the door open for more coherent theories on the genesis of baldness. A piece of evidence he mentioned that ran counter to the Genetic-Androgen Hypothesis was postnatal pattern baldness. Soon after birth, marked hair loss is seen in newborn infants in both sexes. Baldness is seen in the same areas that hair is lost from grown men and women. Male pattern baldness is also common in menopausal women. Postpartum male pattern baldness among women who use contraceptives. And additionally, vertex baldness can be used as a marker for coronary heart disease, myocardial infarction, arterial stiffness, insulin resistance, metabolic syndrome, inflammation and obesity, and even cancer. The genetic-androgen hypothesis of pattern baldness has failed. It's yielded ineffective, dangerous therapies, it's gained a considerable amount of complexity over the years, and perhaps most disturbing, the hypothesis represents a medical culture that discounts the entirety of the individual in favor of fragmentation and reductionism. With a new context of why pattern baldness occurs, perhaps we can better understand one of the prime challenges of modern hair loss research: the physiological environmental controls of hair follicle growth. Until then, pattern baldness research will remain an unsolved medical problem with ineffective, perilous interventions. So that concludes week number 1 of Organizing the Panic. I guess the take-home message is that pattern baldness is not an isolated incident for young males or the aging male. It happens in many different situations. And the idea that genetics and androgens can be the explanation for all these different situations is completely implausible. So if we're to progress a new view of pattern baldness, and that will be coming in next week, the bioenergetic view, it's going to have to explain why Dr. James B. Hamilton's eunuchs and castrates were completely immune to pattern baldness. It's going to have to explain why pseudo-hermaphrodites are equally immune to pattern baldness. and also why contraceptives can cause pattern baldness, why pregnancy increases the rate of hair growth while postpartum decreases it and sometimes can result in male pattern baldness, why menopause can result in male pattern baldness, and why senescent alopecia, and all these different things. So it's a huge task to explain baldness in all these different situations. And the idea that the genetic androgen hypothesis explains these, you have to add many different paradoxes. An easy way to identify theories in science that perhaps have a weak foundation is ones that add mounting complexity over the years. And I think that's a perfect way to describe the genetic androgen hypothesis of baldness. For instance, men don't have higher levels of DHT or testosterone, so you have to go even further and say, oh, it's at the receptor level of the cell. The androgens are somehow causing the hair loss via the androgen receptor. And this just gets more complex, and it doesn't jive with observations about males that are experiencing pattern baldness and women who are going through what can only be described as a stress. And we're going to talk about that a lot next week. So please feel free to rewatch the video. I know it's a ton of information. I think the best way to do it is probably to go through and maybe take notes. But feel free again to ask questions below in the discuss comments thread, or ask questions in the Facebook group. Or if you don't feel comfortable with either of those, just directly email me at dannyroddy@gmail.com. Look forward to next week. Take care, guys.